Good afternoon. In today's presentation, I would like to highlight the clinical results of resulting in those related to epilepsy and speech impairment in children suffering from cerebral palsy. We have been working in the field of cell therapy for the past 13 years and have successfully treated more than 1,300 cases. The conditions treated include chronic spinal cord injury, neurodegenerative disorders, cerebral palsy, diabetes mellitus, amongst many others, and all of them are currently labeled as incurable or terminal. The cells that we transplant are prepared using a novel technology which is patented, and I would like to explain this briefly. Conventionally, the embryonic stem cells are derived from the inner cell mass of an embryo, and the culture process involves the use of conditioned media, feeder cells, feeder layers and other non-human products, which creates several problems in using them clinically. For example, teratoma formations, chromosomal instability, and the need to use immunosuppressants. Our methodology and approach is different. We have derived our embryonic stem cells from a single spare expendable pre-implantation stage fertilized ovum donated during a natural IVF cycle. We culture these cells from a 2 to 4 cell stage fertilized egg, and we culture them in a media which is absolutely free from animal products. These cells are in suspension form and are expandable and easily stored. We have been able to make them into a ready to use product, which is what we use to transplant into our patients. Our technology highlights are, it's a patented technology. It's, as I've already explained, an in-house cultured embryonic stem cell lines, and this cell line we derived in the year 2000. It's non-contaminated, free from animal products, and it's a very stable cell line, and we have moved on to more than 4,000 passages since then. It's a viable, ready-to-use product, simple, very cost-effective, and scalable. We do not transplant, we do not give any immunosuppressants to our patients, and we have not witnessed any adverse events in the last 13 years of clinical use. The slide just gives an account of the milestones in our journey. We started in 1999, conducted safety studies till 2002, established the treatment protocol and started clinical application thereafter. Today, we have greater than 1,300 patients and have a patent for our technology in 66 countries, including the US, Australia, New Zealand, Japan, Israel, and we have peer-reviewed publications in place. Just a brief overview on cerebral palsy, which is a leading cause of disability among children and is caused by the damage to the developing brain during birth. It is a permanent, non-progressive condition, and the child is permanently affected, and as such the family is also affected. The symptoms could be loss of control, problems with coordination, posture, balance, loss of memory, or not being able to be cognitively well, abnormal reflexes, seizures, speech disorders, and many more. It can have motor cognitive issues, and more than 35 to 50% of children with CP also have a seizure disorder and some kind of mental retardation. They may also have learning disabilities and vision, speech, hearing or language problems. As such, these patients cannot be 100% cured, but for improving their quality of life, they need care and support, both medical and personal. Such patients need rehabilitation services, physiotherapy, occupational therapy, speech therapy, and We do have certain medications, but these do not really treat the patient or cure the patient. So, we transplanted embryonic stem cells in our patients, and this slide demonstrates the complete study design. This is a retrospective analysis of 101 patients in the age groups of 2 to 18 years. The treatment is given in phases, and the patients are analyzed using the SPECT scan, the GMFCS, which is an international score. Oops. Okay, doesn't matter. Yeah. Yeah. And the NewTek scores, which is in-house score which we developed so that we could monitor all the other aspects which the GMFCS cannot. And our staff has been fully trained to note any adverse events, immune reactions, or any other antigen antibody reactions, or anything else that you could see in the clinics. It consists of 4 treatment phases, and each phase has been separated by a gap phase. That gap phase was very essential because we had to allow these embryonic cells to grow inside the patient and allow for the functionality to return. We treated the patients with an intramuscular dose of 0.5 ml followed by intravenous injections twice every 7 days. We did transplant the patients through the caudal roots if it was required. That was a clinical judgment that we had to make. And each ml of the entire ready to use product would contain around 4 million cells. Most patients were males, and the total treatment days were, the first treatment day was for around 60 days and the rest would be approximately 30 days. All my data has been verified and validated by clinical research organization as well as the accreditation companies like Moody International and the Quality Austria Central Asia Private Limited. Just a small slide on what does GMFCS mean. It's an international scoring system. It provides the description on the child's motor function, gives an idea to the clinician as to what kind of support you need, what the child might need. It is classified from 1 to 5, 5 being the worst. Once we analyzed our patients, what we saw that there was a huge improvement. This area is before treatment and that is after treatment. It has been classified according to the years. As you can see, 5 being the worst, post treatment you can see how much benefit we have. If we just look at the treatment 1, that means 60 days before and after, all the patients of 2 years, less than 2 years, and in the 12 to 18 year group showed an improvement in score by at least 1 score at the end of T1. That means treatment period 1. High proportion of patients from the age group 2 to 4, that is 92.9% and 90.5%, 92.6% showed an improvement in the score by the end of those 60 days. And please remember, these are cerebral palsy patients. It's only 2 months, because there's a common misconception that, oh, because it's a child and because time goes by and cerebral palsy patients can get better with time, but to document this within these 60 days of taking cell therapy made it relevant that yes, these results are because of cell therapy. SPECT scans were also used as a tool to monitor the effects of embryonic stem cells in cerebral palsy. So, we have international clinical scorings, we have our NewTek functional scores, we have SPECT scans. So, what these SPECT scans did was, it would document the perfusion, that's a scale. So, anything which was green, blue, dark blue and black would quantify how much perfusion is deficit in the brain. And we all know, no oxygen in our brain, 3 minutes, we are all gone. So, if you have a -5 here, we would say that this part of the brain is totally damaged, and as such the patient would have clinical problems. This belonged to a child who was 18 months old, and the child had all the issues, motor, cognitive and speech. This is post-treatment. As you can see, all the improvements have happened. Patient is well. He is speaking. He is actually going to normal school. He has now started walking at 4 years of age, and he walks with a little difficulty, but he walks, and he's gone back, and he talks 19 to a dozen. So as I mentioned, we developed another score, and it's a 32-point positional and directional scoring system to evaluate our patients. In this, 5 is good and 1 is not good. In GMFCS, it's the other way around. With this, we can categorize our sensory systems as well as cognition, and we assessed our speech and epilepsy outcomes using these scores. This is the score for Newtek for epilepsy, and after the treatment you can see that blue is the before and after. So by the score number 3, which was 1 to 2 times every alternate day, became less frequent, like 1 or 2 times a week or occasionally, and number 5 is the score that really went up post treatment, and we had all our patients reaching that level. Their medications continued because obviously we could not get rid of their anti-epileptics in a short period of 2 months, so there is no comment on the medication as of right now. This is the Newtek scores for speech, and at the end of it, again you saw that all of them came back to score 5, and 50% were able to talk articulately, and 35% were comprehensible after the treatment, where they could not speak, were babbling, or just not able to talk. I'd also like to just touch upon our publication on CVI, that is corticovisual blindness, and we documented this with our own scores, and in which you had no perception of light, could identify the objects with blurring of image, could see objects up to a distance of 25, and then a normal vision. After therapy, of the 8 patients who had Newtek scores 1, 3 patients transposition to Newtek scores 5, and another 3 to 4, and 1 each to number 3 and 1. Basically, all my patients showed improvements. This is just an example of a SPECT scan of a patient whose occipital area was damaged. As you can see, he is a doctor's son, and he was a 10-year-old boy, and with this kind of a scan we had him both visually and cognitively impaired. After the scan, we could see improvement in the rest of the brain as well as in the occipital area, and documentation of a significant improvement in the scan with a greater than 60% change was documented by the radiologist and the nuclear scientist, just a before and after. In our patients, we also observed a remarkable improvement in cognitive skills. Overall 69% showed an improvement. They were improved in things like smiling, cognition, awareness, problem solving, eye contact, toilet training, feeding, reflex mechanism, speech, aggression, daily living skills, and following commands. We saw a huge percentage of our children improving in these fields. All the adverse events were reported were minor, and they resolved without any sequel. We did not observe any teratoma formations, any immune reactions. We do not give immunosuppressants, and as you can see, we just had small adverse events which could be related to their diets and to whatever conditions they were exposed to. In conclusion, it is evidenced that by the various studies that the migration and differentiation of the embryonic stem cells could eventually be developed to treat the disorders related to the central nervous system, especially in cases of cerebral palsy. And the best part is that our cells are very small, and that helped it to facilitate and cross through the blood-brain barrier, and that's how we could see the responses just through the IM and IV routes because of the homing in and things like that. And all my patients benefited, and these are our publications. And thank you.
Any questions? Go ahead. Excellent work.
Thank you.
I'd like to ask, do you have differences in your results depending on the age of the patients?
Yes.
I suppose that the smaller the child is, the better it recovers?
Yes, if we are less than 2 years of age, we do see a lot of changes because when you grow old, the brain is not as plastic. Yes, that's one. And then the other thing is that we need time for it to show clinically. My SPECT scan results would come first, as I showed you in that child of 18 months. And today, at around 6-7 years of age, that is 4 years later, the child is, or 5 years later, the child is now walking. So the younger the patient comes for me, the better the results would be.
Which kind of advantages do you see? The cognitive results or the motor results?
The cognitive is much easier, and things like speech and understanding and the eye-to-eye contact and all these yes, they resolve much faster, which is, I think, a very good thing because,
yes,
as a clinician, you want that happening.
Excellent.
Yeah.
Go ahead.
What was your delivery route was intravenous and IM?
We did, this study was with intramuscular and intravenous routes along with some caudal injections. However, now we have moved on and we have started using nasal sprays as a delivery system to reach, yes. And because they are so small, we have the electron microscopy images and documentation that it's less than 1 micron in size. So they all transplant into the brain. That's the main thing.
So how do you know that it's actually in the brain?
Through our SPECT scans, through our clinical results, through our MRIs.
So
We don't tag them, if that's the question you're asking. I don't tag my cells. I don't follow them in because at the end of the day, it's a clinical therapy. So
right. So, but the root of the mechanism. Well, as a clinician, it doesn't matter what the mechanism of action is.
Actually,
It's working.
yeah.
It's working.
yes,
I
that's
understand.
most important for me. Yeah.
But there's two things. One is it would be nice to know whether the cells are actually in the brain
Do you have
in that
animal
particular
studies?
area.
I'll come to that.
And the other thing is that when you do a SPECT scan, you're really looking for a blood flow.
Yes.
And so it could be that somehow by a secondary
Angiogenesis.
mechanism you're getting greater blood flow to the brain.
Absolutely.
And that's enough to do all the things that you're doing, and it's not the cells present in that location that are doing it, but the reaction that they're initiating.
I agree with you that these SPECT scans just tell you the perfusion, and as such it could be the angiogenetic properties of these cells that could show me the changes. However, having said that, because I've been working on other disorders, we do have patients in which the lobectomy was done and things like that, and the brain was extracted out because of a road traffic accident, and we have seen a proper regeneration happening. That was going to be part of another lecture somewhere else. And we have seen that. And as far as doing animal studies, etc., which was your question, see, these are purely human products. And as for me, like when we worked earlier on, we did not believe that animal studies would do anything to really document how it would behave in vivo in a patient. And I agree, there's a lot more to be done. And if someone would like to take this up and prove that this is the cell that goes in, it's fine. That is okay.
Go ahead.
Hi.
Very interesting indeed. I was just wondering if you'd ever conducted a randomized trial
Okay, we've gone through this, and when my ethics committee did give me permission in the year 2003, they did suggest that it would not be ethical from our viewpoint as a physician to deny treatment to patients because they were all suffering from incurable and terminal conditions. But having said that, we have detailed out, and it's a paper that has been published, a prospective study on chronic spinal cord injury patients in which we documented exactly what we're going to see, and there were independent neurologists and everyone in place, and we documented through our tractographies, MRIs, neurological opinions that the prospective, whatever we had benchmark for ourselves was actually translating in the clinics.
But my concern is actually how long the positive clinical effect will last for those treated patients with the embryonic cell therapy.
Okay.
Do you have a plan like to follow for like years?
Yeah. Of course. My first few patients themselves are under follow-up even now. Embryonic stem cells work differently in different disorders, especially if it is, you need to know whether it's a progressive condition or a static condition. So in a static condition like cerebral palsy, chronic spinal cord injury, or a stroke, we have seen that whatever repair has happened, the progress, that repair continues and it doesn't stop. And I've got 13 years of experience, and of course I don't know what will happen further. In progressive conditions like multiple sclerosis or ALS or any other dementia, any other of these conditions, you will need constantly to up the dose and constant treatment because the degeneration is going on. So till a point where degeneration is equaling the regeneration, you get the stability. So stability is what we are looking in progressive conditions. And then you think about improvements. However, we do see clinical improvements because of the dormant tissue which is around, and that then gets stunned into working with these cells. You know, they release whatever they do, and those cells then start working, and clinically we are seeing a lot of benefits. But progressive, we need long-term continuous treatment. And in static, it's up to you.
Thank you for a fascinating talk.
Thank you.
In terms of the dose and how often they would require the treatment, have you had any sort of idea through your 13 years of experience?
Yes, we actually have a very fixed kind of a dose, schedule and protocol. However, we do individualize it, you know, once we see the patient. This is all standardized. So if a patient comes to me with CP, I will say, okay, give him the doses that I just displayed. So we do have it all fixed.
Maybe I missed this point. Can I ask this? You mentioned that there is no immunosuppressive
Yes.
drug administered to these patients. What do you think is the difference between the embryonic stem cells and the method that you use that doesn't induce immune rejection, and also the fact that you injected these cells, as you mentioned, not only could be the secondary result, but also, how do you know that long term they cannot induce any tumor formation or some other, because these cells can also sit in other organs and function not only in the brain, because
Yes.
you have no longer control over these.
My cells are derived, as I said, very early on, and they do not express the HLA-G antigen on the cell surface at that point. We have done our studies on that, and we are going to be reporting that very soon. Having said that, what we believe is I haven't spoken about that, but then we have two major cell lines. One is a neuronal cell line and the other is a non-neuronal cell line. So when I transplant into a cerebral palsy child or a chronic spinal cord, anything, so we use these neuronal cell line. These are actually just nudged into a differentiation process. They're not fully differentiated. So yes, so I know they're not like totally undifferentiated cells or just stem cells that I'm transplanting. These are two cell lines. So I'm sorry I didn't bring that out earlier.
Yeah. So you are injecting the precursor
Yes,
or not?
absolutely, yes.
Thank you.
Thank you.